Bismillah wa salatu wassalamu ala Rasulillah sallallahu alaihi wasallam. I hope the recording is there and you are able to listen. Today we are going to study a very important topic, which is orthodontics and periodontal therapy. We are going to look at it in two ways: the adjunctive role of orthodontic therapy in solving periodontal problems, and the adjunctive role of periodontal therapy in solving orthodontic problems. The interrelationship between orthodontics and periodontics. See, basically, we as doctors and we as dentists do not tend to concentrate on subjects which are not which in which we are not trained too much. But for the patient, for example, I am a periodontist, a patient comes to me, it doesn't make much difference whether I am whether what the end result, the good function of his teeth, the aesthetics, and no pain and health. Those are the things that are important. It's not important that I apply periodontal therapy or I use endodontics or I use orthodontics. That's not much of concern for the patient. Our patient, what they want good function, they want to be able to chew, they want to be able to smile better. So these are things that are in the mind of the patient. So what are the benefits of orthodontic therapy? How can we apply orthodontic therapy in our day-to-day periodontal requirements and teeth? See, sometimes you can have teeth that are not aligned properly. In places where there is malalignment, there can be more accumulation of plaque and food, right? Food debris, plaque, and calculus, and all those things. So that can have an issue. The patient can have an issue with oral hygiene. So you can do orthodontic treatment, teeth alignment, and that will help the patient. The patient can have vertical orthodontic repositioning in certain cases where there are osseous defects. Osseous defects as such, generally we treat osseous defects, especially shallow defects that are around 4 to 5 millimeters. We maintain them non-surgically. But if surgical correction is necessary for this types of lesions, then it can be easily done by reshaping or reducing the pockets. Okay. Sometimes we can use orthodontics to enhance to orthodontic treatment to enhance or to maintain the patient's capacity to clean the interdental areas and all those things. Okay. Again, sometimes we can move the teeth in a vertical format wherein the alignment of the teeth is changed and the alignment of the bone following the teeth is changed, and thereby you can help it. Sometimes a molar is tipped, a tipped molar, especially the mesial surface of the tipped molar, you find a deep pocket. So if you upright that molar, the pocket also disappears and the bony defect is also healed to a certain extent. So orthodontic therapy can again be used to align the maxillary gingival margins. That's a very important thing. Sometimes the gingival margins can be uneven, and if you do the surgery, then most probably you will be doing resective or regenerative surgery. But if the patient needs orthodontic treatment for some other thing, you can also try to solve by repositioning the teeth slightly and changing the positions alignment of the maxillary gingival margins. Orthodontic forced tooth eruption is again a very common thing which is used, especially in cases of horizontal fractures of maxillary anterior teeth. Maxillary anterior teeth with horizontal fractures, you can go in, do a forced tooth eruption, and once the tooth comes, you find enough amount of the tissue of the hard tissue outside, you can make your resistance form, retention form. You can use it directly without going for a resective surgery. Extrusion can also be done for in places where you want to place an implant, but there is a small piece of remaining root or tooth structure which is not in a very good periodontal shape. What you can do is you can do the extrusion, and when the extrusion is done slowly, the bone also forms coronally as the tooth gets extruded. So as the tooth gets extruded, the bone is formed, then it goes for, you can finally extract the tooth and you can go for an implant. There is a lot of bone, you can condense the bone and use the bone. You can go for intrusion of the tooth, and in certain pathological in cases of pathological tooth migration, you can use a bit of intrusion, and then the surgical part and the reshaping of the tooth can be used. Closure of maxillary embrasures. Sometimes you have two teeth, especially the anterior teeth, with a lot of space in between. So there is spacing in the dentition, and if there is spacing in the dentition, what happens is the papilla will not be having a proper triangular shape, and there will be dark triangles in places of papilla. What you can do is you can close the teeth together, then you can bring the teeth together, and once they come together, you can regain certain amount of the lost papilla. You can also improve the tooth position, especially in cases where you want to create space for implants or tooth replacements. So we go on, inshallah, we'll go on one by one. Orthodontic therapy can contribute in many ways to help patients with periodontal problems. Okay, in selected cases, vertical orthodontic tooth repositioning can improve certain types of osseous defects to eliminate the need for resective periodontal surgery. Patients who have crowded teeth, mal-aligned teeth, mal-positioned maxillary or mandibular anterior teeth, they find it very difficult to do brushing, to keep the the biofilm under control. So in such patients, if you do aligning of the tooth, crowded teeth orthodontically, it will help them to maintain their oral cavity in a better shape. Okay. Now, there have been lot of studies dealing with this, right? There was a time when people, only children used to go for orthodontic therapy. Now you find majority of the, at least 30 to 40% of orthodontic patients are patients who are adults. They are adults, like they're in their 30s, their 40s, they go for their for orthodontic treatment. So we have a concern that, does the periodontal tissue destruction contradict orthodontic treatment? No. So we have a lot of studies these days which say that orthodontic therapy improves the possibility of saving and restoring deteriorated dentition, and the risk of recurrence of an active disease process is not increased by appliance therapy. See, remember, this is true only in patients who keep their oral cavity clean. I'll again tell you that if a patient is not keeping his oral cavity clean, if he's not brushing properly, if his biofilm, the plaque is not in the is not to the minimal level, if he's not cleaning his teeth, not brushing, not flossing, then it's not for those patients that we advise orthodontic therapy. No. Okay. Contradictory findings. So what happens is, because of this, we find a lot of contradictory findings in scientific literature on the impact of orthodontic therapy on periodontal health. A systematic review about the effects of orthodontic therapy on periodontal outcome concluded that orthodontic treatment with fixed appliances has little or no relevant effect on periodontal clinical attachment levels. It has little or no effect or no clinically relevant effect on periodontal clinical attachments. So this is from a systematic review. But you have to remember, all these things are true only if the patient is keeping his oral cavity clean. So if the patient is not brushing properly, not flossing properly, then in such cases we should not rush for orthodontic treatment. So what we find out is the orthodontic tooth movement per se do not cause periodontal attachment loss or gingival recession. This we must understand, that the movement by itself will not cause periodontal disease or recession. See, orthodontic therapy, again, in severe periodontitis patients, there have been a lot of discussion over this. We, in this new classification, like for example, in the stage 4 periodontitis patient, orthodontic therapy had no significant impact on periodontal outcomes. This is what we are getting with the newest available literature. So in a lot of studies that were done, what we found out is, in studies in which periodontal outcome was reported before periodontal therapy, combined periodontal and orthodontic therapy has a significant benefit on clinical attachment level, probing pocket depth, and radiographic bone level. So if you combine periodontal therapy and orthodontic therapy, especially in certain adults, it helps them a lot. It helps them a lot. Patients with stage 4 periodontitis, some of the patients, they get a lot of help because of this. So in fact, many clinical studies have shown clearly that with adequate plaque control and orthodontic treatment in patients with reduced plaque control, orthodontic treatment in patients with a reduced but healthy periodonticium achieves the orthodontic objectives without aggravating the periodontal condition. That is, if the patient has a healthy periodontium, even if it is reduced, even in a reduced periodontium, if the bleeding is not there, inflammation is not there, the patient is keeping his oral cavity clean, oral hygiene is good, then in such patients, even if there is already a lot of destruction, orthodontic treatment is not going to create any problem. So that is very important for us to remember. Okay, tooth malalignment. We started with tooth malalignment. Frequently, orthodontic therapy is carried out to correct tooth malalignment, which appears to be associated with gingival inflammation, especially if the patient is having crowding, if he's having problem with the alignment of the teeth, the food gets accumulated, and it is difficult for certain patients to clean the areas because the teeth are not in alignment. So in such cases, we can go and do orthodontic treatment. But what we should understand is a large proportion of this effort is wasted, because if the patient is not having, his patient's home care is inadequate, if he's not cleaning his teeth, then the patients who are not cleaning his teeth, if you go with orthodontic treatment, then they will come up with more complications. Such treatment is just justified when the patient is obviously trying to control plaque deposition and fails only in the areas of malalignment. Remember, if you have a patient, anterior crowding is there, other teeth are okay. So if you see the anterior teeth, the place where there is crowding, lot of plaque and calculus, it's good. You have to go there, get orthodontic treatment done. But if you see that places where there is no crowding, still he is not cleaning the places without crowding, then there is no point in asking the patient or advising the patient to go for orthodontic treatment. Then orthodontic forced tooth eruption is again a very, very important tool. See, it's like an extra tool in our hands. So orthodontic forced tooth eruption aims to expose more tooth structure while maintaining the position of the gingival line and the alveolar bone. It is a very conservative treatment, but there is a problem. The problem is it is too time consuming. You use orthodontic treatment, it's gonna take you more time, longer time than you go with the normal surgical periodontal treatment, exposure of the tooth. But it is useful in cases where there is isolated teeth requiring crown lengthening. So if you have a single tooth which is horizontally fractured, especially in the anteriors, you can go with orthodontic forced tooth eruption, or orthodontic, whatever you want to call it, orthodontic extrusion, and that's going to work very well. A bracket is bonded on the crown, and vertical forces are applied to force the eruption of the tooth till what till the level the appropriate amount of supragingival tooth structure is exposed. If you find this much amount of tooth structure is enough for making your finish line, your retention resistance form on the tooth, then it's perfectly all right. And then you go with the crown. It is generally used with maxillary anterior teeth, especially from canine to canine, because it doesn't change the position of the gingiva. It doesn't change the position of the gingiva, but sometimes it can also be used for posterior tooth. This is a beautiful case where a single premolar is forced and it is brought to the level of the other teeth, and then the bracket is placed slightly apical, and once the tooth comes coronally, they are going to remove the bracket and they are going to go with the crown, and that's what they have done. It's a very simple and easy illustration. What are the contraindications for orthodontic orthodontic forced tooth eruption or orthodontic extrusion? See, it should not be done in extremely compromised or hopeless teeth. There is no point in doing it in hopeless teeth. What are you going to? Why do you want to go with an orthodontic treatment when you are going to extract the tooth sooner or later. It doesn't make so much sense, except in case you want to make the bone be present there so that you place implant. Root proximity and very divergent roots, you're not going to do orthodontic treatment because that extrusion will be a very long process and a difficult process. And sometimes you are going to expose the furcation area, or you're going to create more troubles than you are going to benefit out of it. Ankylosed teeth. If in case the tooth is ankylosed, you cannot do orthodontic treatment with it. Inadequate root length with a very unfavorable crown to root ratio. Masalan, you have a horizontal tooth fracture, you found the root is very short, and you are going to pull the tooth towards the occlusal plane. With orthodontics, you are going to slightly extrude the tooth, and then what you find is at the end of the treatment, your crown root ratio will become unfavorable. Then in such cases, you are not going to go with orthodontic extrusion or orthodontic forced tooth eruption, whichever way you like to call it. And vertical fracture of the entire root. If you have a vertical fracture, again, it doesn't make sense to extrude the tooth. See here, there is a very simple case of extrusion, forced tooth eruption of a premolar. Again, they used a different way. They used a different orthodontic tool or technique to make the tooth come to the level of the occlusal level. I think these things are very important because sometimes a patient doesn't want to go for a surgery, and sometimes you think it is easier for him. Sometimes he wants to go for orthodontic treatment for some other reason, and you can add this up, and the treatment will be wonderful, and it will be very easily completed. So all these things this knowledge should be there in the back of our mind when we are treating. If the tooth is supra erupted, intrusion and leveling of the adjacent cemento-enamel junction can help level the osseous defect. Okay, so orthodontic intrusion is done sometimes when you want to bring the level the osseous defect. So if the tooth is supra-erupted, masalan in case of pathological extrusions, with pathology the tooth starts extruding and you want to bring it, level it, then you can do it, and with that you can also manipulate these intrusion in a sense that you level the osseous defect. Okay, and once you complete this intrusion with orthodontic treatment, you have to allow for 6 months of time so that the tooth is stabilized, and then you reassess it periodontally. Sometimes what we do is they do orthodontic intrusion, they do slight adjustment of the tooth surface, and sometimes it is also accompanied with periodontal surgery. So we can put all these three together and we can treat an osseous defect. So see, this is a very beautiful case. It's there in your Carranza. The maxillary first molar is supra erupted because there is the opposite tooth is absent, it's not there. What they did is they have done they have intruded it slightly orthodontally with the use of orthodontic treatment, orthodontic therapy. And once it got intruded a bit, they have adjusted the surface of the tooth, and now this tooth is beautifully fitting in its perfect space, and the tissue that was because of the destruction of the tissue that was lost, the bone has also got leveled with it. But again, in most instances, see, and in sometimes, especially when there is occlusal discrepancies, we also already studied about occlusal discrepancies, how supra eruption can cause occlusal discrepancy. We read it very. I remember I gave you a lecture, and you also had lecture on trauma from occlusion from other stuff, so you know it. So sometimes orthodontic intrusion is the very, very, very least invasive, the best answer to correct discrepancies in occlusion. But sometimes the patient will say, no, I don't want to go for a lengthy time of treatment. Some patients will not be interested in wearing orthodontic brackets or braces. So these are all things that are very important. You should keep in mind. But if a patient where there is slight supra eruption, if the patient wants to go for orthodontic treatment, then I think it should be done, and it will be very helpful for the patient. We go for studies, two of these studies. One of them is by Correnti et al. I am sorry if I do not spell the Western name so properly, recommended treatment of infrabony defects in anterior teeth. How did he recommend? He said by combining surgical periodontal therapy, yani you do flap surgery without much of other things. You do a flap surgery and then you go for intrusive orthodontic movements. And what he said was he found that there was significant attachment gain and radiographic bone fill in cases of these patients. Again, I think this, if I am remembering correctly, he did with around 200 patients. And then this Re et al., he also found a 50% reduction in recession after intrusion of periodontally compromised teeth. These movements are, however, see, remember, these things are not predictable because periodontitis is a multifactorial disease. If the patient is not keeping his oral cavity clean, if he has other systemic diseases, so all these things should be taken into account before you go for treating periodontal disease. Okay, in the presence of shallow circumferential bony lesions, orthodontic intrusive movements may resolve the defect. So it should be remembered that it is very helpful when you have shallow defects. But if these defects are deep, they are first treated with periodontal regenerative procedures. I hope you'll be studying periodontal regenerative procedures. If you have not already finished that, you will be studying very soon. Orthodontic treatment of osseous defects. Again, it can be used for treatment of osseous defects, hemiseptal defects, advanced horizontal bone defects, furcation defects, root proximity, fractured teeth and forced eruption, what you call as orthodontic extrusion sometimes. So all these things can be done for treating the osseous defects. See, now we go on for hemiseptal defects. Hemiseptal defects are basically one wall defects. That is, only one wall is remaining. So you have three types of vertical defects: the three wall defects, which were also called as intrabony defects. Then you have two wall defects, and you have one wall defect, which is hemiseptal defect. Sometimes some authors also, like how this Carranza says that one or two wall defects, hemiseptal defects, but basically hemiseptal defects are one wall defects. Sometimes you can have slight amount of combination in these defects. That is again possible. That often they are often found around mesially tipped teeth. I already told you mesially tipped teeth. I'll show you the photographs of a case in the next slide. Usually these defects can be eliminated with the appropriate orthodontic treatment. How are you going to do it? You are going to upright this tooth. In the case of tipped teeth, tooth uprighting and eruption of the tooth levels, the bony defect will be very helpful. Mesially tilted molars usually present an angular bony defect on the mesial aspect. If you see the mesially tilted molars on the mesial surface, you always find a defect. So once you upright this teeth, what you find is that this defect resolves. This, I'll show you a very beautiful case, I think. Yeah, this is a very good case, and again it is from your Carranza. You can see the mesial molar, it has tilted and there is a defect. What they did was they used orthodontic treatment. They uprighted this molar. What did they do? They uprighted this molar, and once this molar got uprighted, the defect, the bone got leveled, and the defect simply disappeared. So these are things which are very important. You should have them in the back of your mind. And these days, a lot of adults go for orthodontics. So it's not a big deal, not very difficult for us to convince the patient. Again, here is a very beautiful case where there is orthodontic treatment being done. Yes, here it's a very good case where orthodontic treatment is being done. There, the bone is being leveled. See, remember, when there is a loss of bone or bone destruction, I don't know if you know where to place the brackets and all those things. I don't know if you know it or not, but basically they place, to the best of my knowledge, in the clinical crown or the anatomical crown, they place it in the center of the crown on the buccal surface. So when you have a bony defect, what they do is they do a slight adjustment. They place the bracket or the braces, the way you might like to call it, based on the bone level, rather the crown, based on the crown. So what they do is they bring it slightly adjusted, and then they adjust the surface of the tooth so that the bone gets leveled. Here, this is a beautiful quick case. Two central incisors are supra-erupted, What they did was they placed the brackets and they tried to intrude the tooth, and yes, and the central incisors of the incisal edges of the central incisors were also slightly adjusted. Coronoplasty was carried out, and now you see the end of the treatment. The teeth look more better, in better place and in better shape, and they look better. The entire smile has improved, and also the bony defects have been treated. Okay, advanced horizontal bone loss, again they can be, it is used in cases of advanced horizontal bone loss. We saw it in the earlier with the earlier case. See, these problems are corrected by using the bone level as the guide to position the brackets on the teeth. See, you place the bracket based on the bone level. You try to bring the bone level at a single place so that there are no defects. You equilibrate and or level the bone using the placement of the brackets, and the placement of the brackets is based on the bone level, which is used as the guide. And if there is slight supra eruption of the tooth, or somewhere the crown portion is appearing slightly towards the occlusal surface, then you can adjust it and equilibrate the teeth. Again, furcation defects, they used to use this a lot before. In some patients, they used to do hemisection of the mandibular molars, and then they used to with a class 3 furcation involvement, they used to move the roots apart. See, what is class 3 furcation involvement? Basically, the class 3 or grade 3 furcation involvement is like your Glickman's furcation involvement is the through and through. If the probe goes and the tissue is destroyed in the furcal area. So the problem is the patient is unable to clean this furcal area. So what they do is they do hemisection, and after hemisection they slightly make the teeth move, the roots move away. Mesela for the mandibular molar, if you create a space of 7 to 8 millimeters between the two roots, the mesial root and the distal root, the furcation is over. There is no furcation. So then the patient can brush, and these the roots will act as two separate premolars. So this they used to do, but nowadays we don't do it that much, because like post for treatment of furcation, especially class 3 and class 4, the results are not so much promising. And the second thing is, now with the presence of implants, it is very simple. Pull the root out, pull the tooth out, clean the socket, place an implant, and that finishes in within 10 to 15 minutes. You place a single implant, and the patient is going, and you are free. So because of that, in our back of our minds, generally these days we don't use hemisections and all those things so commonly. But still, patients, it can be done in patients who are very insistent on hemisection, where the tooth is good, where the gutta-percha can be filled properly, endo problem will not be there. In such cases, yes, of course, we can go for with this uh, this type of treatments, especially if the patient is willing and the orthodontist is okay with it. There is adequate amount of tooth surface remaining. See, this is a very beautiful case where they have used orthodontic brackets and the bonding the two roots, and they have separated the two roots, and you can find a distance of 7 to 8 millimeters post treatment, and that is perfectly fine. Now these two act as two separate premolars, and the patient will be using them for quite a long time, hopefully. Orthodontic treatment of gingival discrepancies. Again, it is a very good subject. I think I did not take all the stuff from your textbook, because I wanted it to be as less as possible, because I wanted you to understand the subject rather than going for a long discussion. If any one of you is interested, I request him to please read a book. As all of you read the chapter in the book, because it's a very interesting chapter, and you can have better understanding than this short comprehensive 1 hour lecture, because it's not possible for us within 1 hour to read the entire chapter to you and bring it to you. So this is very important. See, orthodontic treatment of gingival discrepancies, especially when you have uneven gingival margin. So there is a relationship between the gingival margin of the maxillary anterior teeth, and it plays a very important role in the aesthetics of the oral cavity. The smile what you see, the teeth, you see the pink the pink part of the smile, the white part of the smile. The pink part of the smile is your gingiva, your, then you see your the lips of the patient, all those things you see. So if the gingival margin is uneven, then there is a problem. It doesn't look good, the patient, it doesn't, aesthetically it is not appealing. So the problem is, these days aesthetics have become one of the most important reasons why patients should go for treatment. It's a very big motivating factor for the patient. So you have to take care of the gingival margin of the T2 central incisors should be at the same level. The gingival margins of the central incisors should be positioned more apically than the lateral incisors and at the same level as the canines. The contour of the labial gingival margins should mimic the cemento enamel junction of the teeth, and a papilla should exist between each teeth. So these are the basic things you have to keep when treating. So in cases of uneven gingival margins, you can use slight bit of intrusion, a bit of eruption. So you can play with your orthodontic brackets in a perfect manner, where you keep the aesthetics of the gingiva along with the aesthetics of the teeth, and you can bring the gingiva to become even. See, remember, when the tooth is orthodontically pulled, extruded, the gingiva, the alveolar bone, also moves with it. So it can be used to change and camouflage to treat the uneven gingival margins. Significant abrasion and over eruption. This is a very important topic, but I think some of this part of this topic is like you would have studied this topic, especially in your operative dentistry, to treat, especially and even in prosthodontics, fixed prosthodontics, to treat patients with bite collapse, to treat patients with a lot of abrasion, especially patients who have bruxism, destructive dental habits such as bruxism. You can find that maxillary and mandibular incisors are like a lot of the tissue has abraded. You can find over eruption in these teeth. So you will find a lack of crown lengthening and crown length in the patient. I'm sorry, not crown lengthening, crown length in the patient. So in such patients, you have to go with treating these kinds of treatment. There is a very good book by Dr. Subir Banerjee on treating this tooth wear and abrasion. I think it's very practical. I don't remember its name, but you can read it. It's from King's College, London. So it's a very good book. If you can catch hold of this book, you can read it. This is a very good subject, especially if you find patients who have chewing habits, like gum chewing, chewing of pan, chewing of betel nut, chewing of tumbak. All those things, these habits can cause a lot of destruction, abrasion of the tooth surface, and even bruxism. Even bruxism is a very important factor. So then we go on to open gingival embrasures. This is very simple and very commonly treated. Open gingival embrasures are common, and they have a negative effect on the position of the papilla of the teeth. So in such patients, you have to sometimes go with uh, orthodontic treatment. You can bring the teeth close, and once the teeth come closer and the space goes off, the orthodontic the spacing goes off between the teeth, then the gingival embrasures generally get filled with the gingival tissue. So it's very important. Okay, furcation. Okay, so we have studied about furcation involvements. We have studied about the gingival things, all these things, and it's like quite commonly useful, and it's very useful in your day-to-day practice, because you are still in your phases. You have come up from your fourth year, so you are basically doing scalings, root planings. You learned how to do it. You did a few cases with these things. Now you will move on to further treatments, and within 1 or 2 years, once you are in your sixth year, your comprehensive, so then you will be dealing with patients with more complexities, and you will have to give them more treatment options. I just cannot tell my patients, see, my other dentists will be doing this, but I will be doing only scaling root planning. It's not possible that way. So I think the more skills you learn, the more things you understand, it will be better for you to treat your patients. So patients with orthodontic problems, like once anything that you stick to the tooth surface, you will have more plaque, more calculus. هذه شيء طبيعي. So if you have a bracket on the tooth surface present, what will happen? You will have more plaque around the bracket. So once you have these appliances, removable, functional, fixed, there are chances of having lot of there is a chance that the patient needs more oral hygiene, professional as well as home care measures, more of the. Okay, sometimes the frenum will be attached in an interdental space. It's affecting the closure of the teeth. You have to go for frenectomies, all those things. Generally, earlier what they used to tell us is what I knew from uh, I don't know if there is any change to this currently. Generally, what they used to tell us is like the orthodontists, like once they finish the first phase of the fixed orthodontic treatment, then they will send the patient for frenectomies, because sometimes the scar tissue that forms with the surgery can prevent the closure of the site. So they used to complete the first phase of the orthodontic treatment, and then they used to continue with it. Removal of gingival invaginations of the after orthodontic treatment. Again, this is a very, very important thing. Gingivectomies, patient go with gingivectomies. Again, with gingival enlargement, sometimes even inflammation after the accumulation of due to the accumulation of plaque and around the if the patient is not careful around the orthodontic appliance. Mucogingival surgery, sometimes we do mucogingival surgeries, or especially in cases of thin phenotypes, we are asked to do mucogingival or the periodontal plastic surgeries before the treatment, and sometimes after it. Treatment of iatrogenic problems, sometimes you have iatrogenic problems during the treatment, and then the periodontal treatment is necessary. So basically, you should know one thing: when if a patient is having periodontal infection, when can we start orthodontic treatment for that patient? Okay, there are different views about this. You have different months and dates. Your Carranza says it is 2 months, but what I found to be the most, which I agree with, is like for after non-surgical treatment, or in cases of uh, resective periodontal surgical treatment, or just a access flap, we should wait for 3 to 6 months based on clinician's choice, then go for orthodontic treatment. See, in cases of regenerative surgical procedures, we wait for 9 to 12 months. Don't rush in. Wait for 9 to 12 months for the tissue to form, because see, mobility is the enemy of movement of the teeth is enemy of any regenerative procedure. If you do regenerative procedure and the tooth is moving or disturbed, then the regenerative procedure generally fails. So this is what I think is the most appropriate timing. But I think in the newer Carranza, it said that after 2 months of active treatment, the treatment it can go be we can go for the for the orthodontic treatment. Yes, it may be okay for non-surgical treatments, but once we go for regenerative procedures, I think we have to give a longer period of time. So 3 to 6 months after non-surgical or surgical periodontal treatment, and 9 to 12 months after regenerative surgical procedure. So once you do surgery, wait for a certain period of time, then start with the treatment. See, there is no consensus on the best moment to apply orthodontic forces in a periodontitis patient. See, this we should remember. It is mandatory to start orthodontic therapy once periodontal health has been optimally restored. That's what your Carranza says, and that is the right thing. You have to wait for a period of time. Once you feel the health is perfect, restored, if there is no infection, active infection remaining, then you can go for orthodontic treatment. Acceptable periodontal status for orthodontic treatment. It is important to achieve low rates of full mouth plaque and bleeding on probing after active periodontal treatment with scores of less than 25% of the previous ones. So if you have a lot of plaque, if you have a lot of calculus, if you have a lot of inflammation, then there is no point that you go with orthodontic treatment. Reduce it, go with the minimal of that, then you can go with the treatment. They recommend that these low optimal plaque values without clinical gingival inflammation be reached and maintained during the entire phase of orthodontic therapy. So once if there is again infection or raising due to the patient is not cleaning his oral cavity, home care is not good, then it's going to trouble you. Biological efficacy of orthodontic treatment: a combined periodontist, orthodontist diagnostic and treatment endeavor in periodontally compromised patients can result in improved masticatory efficiency by a more balanced ortho-occlusion brought about by a realignment of the migrated teeth. The realignment may also result in the periodontal structures being able to carry out their assigned functions. So if you go for realignment, you go for orthodontic treatment in patients who maintain their oral home care very well, who don't have major systemic problems, then it is very, very good for the patient. You bring the smile back, you bring the alignment of the teeth back, and you have already removed the periodontitis infection, so the patient is going to enjoy it and be happy with it. I have tried to concise this as much as possible, and it's a very huge chapter. I've tried to concise it as much as possible, and I think this is the like very clinically oriented chapter, and I request you, all of you, to at least read the chapter one time from the textbook. Don't miss it. It's a very good chapter, and I request you to read it, and I hope you will enjoy your exams and the holidays after it, and you will be we'll see you again inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh. Who understands hadith? Salaf Allah. هم قرأوا هذه الأحاديث وقرأوا هذه الأحاديث. السلف النواصب قرأوا هذه الأحاديث وهذه الأحاديث، كلاهما صحيح، يعني ما في شك لا غبار. النبي عليه الصلاة والسلام: اللهم هؤلاء أهل البيت. قال اللهم هؤلاء. no doubt، ما في فرق. لما جاءوا المسيحيين في النجران قالوا: تعالوا ندعو أبناءنا وأبناءكم ونساءنا ونساءكم ثم نبتهل فنجعل لعنة الله على الكافرين. ما تقول أهل التقوى تعالوا، ما كان أهل التقوى تعالوا. قال اللهم هؤلاء أهل البيت. قال اللهم قال هذه حديث يعني مليون في المية، ما فيش تفسير القرآن بالآية هذه. الروافض الراشد قرأوا هذول الأحاديث وبقوا يسقطوا أمهات المؤمنين. النواصب قرأوا الأحاديث بفضائل العامة المسلمين قالوا لا 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 لا، هي مستحيل. النبي عليه الصلاة والسلام كل المتقين هم أهل البيت. فنحن أهل السنة نتبع الصحابة، نتبع الأئمة.